including microwave ablation, radiofrequency, irreversible electroporation, cryoablation, and as well as and laser treatment. All these techniques has many advantages, but there are also some limitations that we are going to discuss. The main target is to optimize our ablation technique in order to get the best outcome. And this is an interaction between the technology, the operator experience and learning curve, as well as the tumor behavior and biology. And the strategy is to use a cytoreduction of the tumor and downstaging. Different advantages are for ablation therapy, being selective damage to the tumor with preservation of the lung. This is important for patients with limited cardiovascular disease due to pulmonary fibrosis. And also, it's a minimally invasive technique, and in some cases we do it as with only one overnight staying at the hospital. And the objective of the treatment, as you can see, is to induce a localized ablation or destruction of the tumor tissue with safety margin in order to control the tumor and to preserve this safety margin is the same like surgical principle in order to kill off micro-infiltrations of the tissues surrounding the lesion. The hyperthermic techniques like laser, microwave, or radiofrequency depends on induction of protein denaturation of the cell components, the enzymes, the cell membrane, and also the nucleus or DNA materials. And this, by increasing the temperature above 45, we can induce protein denaturation, and getting the temperature above 100. This will make the coagulative necrosis of the tissues more rapid, but induces also carbonization and also gas production and vaporization. In comparison to cryotherapy, this induces ice crystal within the cells and outside the cells, and this will lead to changes in the osmolarity across the cell membrane, as well as mechanical crushing of the cell membrane, leading to its damage. This is a video for liquid nitrogen over a cell, and this will lead to rupture of the cell membrane and destruction. And this is the principle for the cryotherapy. You can see the ice pools surrounding the cryo probes, and the cell necrosis starts but at minus 20 degrees. And this is post cryo ablation. You can see the zone of necrosis. Irreversible electroporation is a nice technique, but however, it requires multiple electrodes to be inserted, as well as the necessity for the general anesthesia in order to include or to induce the tumor control. And you can see these are multiple electrodes applied, and this is the zone of ablation in an ex vivo experimental study. The HIFU could be applied, but mainly for metastatic diseases at the pleural surface, as the ultrasound waves cannot go through the lung parenchyma due to air interface. Patient selection is the core of this treatment, and we have different concepts, either curative to include long-term survival associated with local tumor control, but also neoadjuvant in order to convert non-surgical patients into surgical patients. I will show you some examples in this way. Symptomatic treatment is to control symptoms like painful metastasis, and palliative in order to improve patients' quality of life for cases of inoperability or post-surgical recurrence or failed chemotherapy. In different institutes worldwide, the inclusion criteria are summarized in this slide. Inoperable or irreversible primary or metastatic pulmonary disease, these are the inclusion criteria, or even operable, but when the patient refuses surgery. Non-candidate patients for surgery due to limited lung functions, and patients post-operative or recurrence. But the most important is the number of lesions not exceeding 5 metastases or lesions, And the maximal axial diameter, it's better to be up to 3 centimeters, but never over 5 centimeters. The exclusion criteria: progressive lung disease and non-controlled primary in cases of metastasis, or when the number of lesions above 5 or the axial diameter is above 5, and non-correctable bleeding profile of the patients. According to the literature, the most important positive factors that are associated with the best results is the tumor size, between 2 to 3 centimeters, the location at the outer third of the lung parenchyma. Negative factors are lesions above 3 centimeters in diameter and adjacent to major structures like the aorta or the pericardium or the trachea, and proximity to the apex and the diaphragm. This is an example of a tiny lesion that is, This is a tiny lesion at the apex of the lung, and you can see here during the process of ablation and post-ablation, we can see that the presence of the scar, this scar is due to the post-ablation process, but in comparison, this is a large lesion with speculations, and doing ablation in such a case is associated with failed controlling primary and leading to tumor progress. So patient selection is very important. Another factor is the location of the tumor. You can see here, this is a lesion lying on the pleura. It's in diameter at 3 centimeters. This is during the microwave ablation of the lesion. And 24 hours post-ablation, you can see a wide, large zone of ablation. And 3 months, you can see atelectatic zones at the zone of ablation. And 6 month post-ablation reduction of this size. And even if we did here PET scan, you can see there is no activity denoting complete successful ablation of such a lesion. So this is a factor. The peripheral location of the lesions are significantly controlled in comparison to other centrally located lesions. Look at this example. This is a small lesion. However, it's near the hilum of the lung. Puncturing such a lesion associated with increased risk of bleeding, and the process was not adequately done, so the patient had progress in this lesion. So central lesions are badly controllable. This is due to the effect of the heat sink effect. The heat sink effect is that while we are applying our energy, the presence of the blood vessel near the lesion will lead to cooling effect and deviate the energy away from the core of the tumor, and this results in the safety margin here is adequate. However, the safety margin near the blood vessel is badly controlled. The radiofrequency, just to say it a very simplified way, the radiofrequency applies that we apply an electrical current through the patient. The patient's body allows the conduction of electricity, but part of this electrical current is lost due to the resistance, and this lost part of energy is converted into heat. The most important factors that hamper the effect of radiofrequency is this carbonization and the air, which hampers the transmission of heat this electrical current through the body and through the tumor. These are the drawbacks. So different electrodes are available in the market for the radiofrequency technique. Either monopolar or multiple electrodes could be applied, or multiple tined electrodes, or using internally cooled system. But how we do the ablation therapy for patients? We do it, of course, for the lung in under CT guidance. The patient lie supine or in lateral, but prone position is not preferred by many of the patients. We do surface marking at the shortest and the safest access to the tumor, and afterwards we start applying the electrode or the antenna in a very cautious way, like doing a lung biopsy, and afterwards we give an amount of energy correlated to the size of the tumor. Multiple overlapping technique could be applied in order to ensure wide zone of ablation to ensure tumor control. This is an example for a 65-year-old female patient with colon metastasis located at the upper lobe at the left side, during radiofrequency, the needle is inserted inside the center, and due to excessive amount of energy applied, you can see the presence of wide zone of ablation and even with a cavity formation. However, most of these situations we see, and due to consecutive fibrosis and retraction, you will see that there is no evidence of enhancement at the lesion, as well as reduction of the size, denoting its fibrous component. Overlapping technique, as I described, you can see that you can put the electrodes, move it at different locations in order to ensure a wide zone of ablation. And this is the outcome after 9 months. You can see a fibrous atelectatic zone at the zone of ablation. Even here in this metastatic deposits from in a 48 female with a metastasis from breast cancer, you can see at the pleural surface and contrast enhancing lesion, and after ablation you can see no evidence of enhancement at the ablation zone with adequate control of the tumor. The most advantage of ablation over surgery is the treatment of multiplicity of lesions. You can see this is a colorectal cancer patient from sigmoid, and he had multiple metastases, one in the left lung at the lingula, and 2 lesions, one in the middle lobe and one in the right lower lobe. And we did the ablation for all the 3 lesions at different sessions to avoid the incidence of complications bilaterally, 24 hours post-ablation, showing the ground glass opacification at the ablation bed. And the patient was tumor-free for 2 years. And you can see this is in this animation, no evidence of tumor residual at the ablation zone. I can give time till the scan to be done. Here the fibrotic changes at the ablation zone with no evidence of tumor residual. Ensuring a wide zone of ablation is important in order to induce proper tumor control. This is pre-ablation, around 3 centimeters in diameter, and post-ablation you can see 18-month post-RF, you can see the presence of atelectatic zone denoting successful ablation. Laser, we are one of the centers that apply this technique. It's done by converting the laser beam and the fiber-optic energy into heat due to the interaction of the laser beam with the tissues. And this is the system that we use. This is the introducer and applicator, and this is the laser optic fiber inserted inside this applicator. And I will show you some CT images. This is the metastatic deposits and treated by laser. We applied the probe, and after insertion, we withdraw the probe and leaving the laser fiber inside the lesion, giving a large amount of energy. And you can see during the process of cooking the lesion, you can see the presence of cavitation and destruction of the tissue, leading to the formation of air bubbles around the lesion. And this is after withdrawal of the applicator. You can see a cavity denoting destruction of the tumor. As I showed you different examples, the electatic bands are also here. Is important to know that it has no enhancement in contrast enhanced scan, as well as reducing in size with follow-ups. The microwave has a better advantage than CT, being rapid, and you can apply a large amount of energy at a shorter time. And it does not it's not hampered by the effect of the gas bubbles, as well as the electrical impedance that we mentioned in the radiofrequency. I published with our group here in Radiology in 2011 our outcome results for ablation therapy of metastatic deposits. Complete successful ablation was around 73%, and the statistical significance was for lesions up to 3 centimeters. And this is why we have to select the patients in order to induce the best outcome. Peripheral lesions, as we described before, were more controllable than central lesions, and there was no effect regarding the histopathology of metastasis. And this means that we can apply the ablation therapy for all types of metastasis and also for primary lesions, as we are dealing for coagulative necrosis and is not hampered or affected by the histopathology of the tumor. Complications is the pneumothorax, and the incidence was around 8.5%, and pulmonary hemorrhage, and it's a self-limited complication. Also, Hiraki et al. In the European Journal of Radiology in 2019 that showed also that in the results regarding the ablation, the local tumor control was around 97% in the first year, and it's not hampered by the histopathology of the tumor. This is another example of different lesions. I will shift to the complications. What are the risk factors for complications? Pneumothorax is one of the most common complications, and the risk factors for such is the COPD. This is an example of pneumothorax happened due to COPD. Also, the depth of the lesion, the greater the depth of the needle penetrating through the pleural surface and the lung will result into increased incidence of pneumothorax. Also, the basal location of the lesions due to the effect of the diaphragm and leading to more shearing effects to the lung parenchyma and injury with development of pneumothorax. This is very important even for your practice regarding the lung biopsy. Never cross pulmonary fissure. This is here, while crossing the pulmonary fissure, leads to development of pneumothorax immediately. This factor increases the risk of pneumothorax 14 times more than non-crossing a pulmonary fissure due to the you are crossing multiple pleural surfaces at the same time. So, positioning of the electrode is one of the important factors. Look at this lesion is located at the pulmonary vessels, so it's better to get more parallel to the lesion rather than, in this example, getting through perpendicular to the vessels, which will result into the development of hemorrhage. So this is important because hemorrhage, we are depending on the coagulation profile of the lesion and excluding patients with pulmonary hypertension. Most of the hemorrhage is alveolar hemorrhage. Look at it is self-limiting. The patient may experience a blood-tinged sputum, and it disappears within 48 hours as long as being with adequate tumor profile. Also, a long axis, this is more associated with pain. This is an obese patient, has a huge breast, and so we didn't go through the gantry from the lateral aspect, we get through the anterior aspect, and this is associated with increased risk of crossing vessels and development of hemorrhage. But one of the techniques that shows the importance of this ablation technique is that post-pneumonectomy. This is a patient who had a metastatic deposits post-pneumonectomy, and of course, the patient was resistant to chemotherapy and excluded all protocols. So we get, after consultation of the tumor board, we decided to go for ablation. 2 lesions were ablated in separate sessions, and of course, we need the support of the intensive care as well as the immediate insertion of chest tube if there is evidence of pneumothorax. And the patient was tumor-free even for 2 years post-ablation, denoting as an advantage for ablation in comparison to other surgical interference. Another lesion, which is due to metastatic deposits from a breast cancer. In this patient, we did the procedure, and you can see here the potential use of MRI in the follow-up. You can see the comparability between CT and MRI, showing the atelectatic zones, no evidence of contrast enhancement, denoting complete ablation, and even in PET-CT after 18 months showed no metabolic activity at the ablation zone. So, to conclude, ablation therapy of lung tumors could be utilized as a safe therapeutic tool for the treatment of pulmonary neoplasm, and the efficacy of treatment is mainly governed by the pre-ablation size as well as the location of the tumor, whether in the periphery or near to the hilum of the lung. Successful ablation is more for lesions up to 3 centimeters in diameter, and careful selection of the patients is important to ensure optimal outcome. Thank you for your attention.
Okay. Thank you, Dr. Nour.